Thank you, Dr. Serene and Professor Seema. It's real pleasure to kind of present this topic to you, which is becoming a complete necessity and requirement in the countries all over Europe as well as the United States. The reason of it being to provide the safe and quality patient care to the patients. If you look at the Hallstadian model of medical education, we believed in see one, do one, and then teach one. That was a simple method we have been adopting since ages, but which is obsolete now. Now it's see one, then practice many, which will become simulation training, then do one, and then teach one. This will make a physician or a healthcare worker competent to take care of the patient. Now, what is simulation? And Dr. Gaba from Stanford University wrote one piece about 25 years ago. Simulation is a technique, not a technology, to replace or amplify the real experience with guided experience that evoke or replicate substantial aspect of the real world in the fully interactive manner, and which will come into a minute. The history of simulation concept is not new. It has been practiced in primitive forms in the Greek times by using patients as simulators. The first medical simulators were simple models of human beings varying from different cultures and continents. The introduction of human patient simulation towards the 20th century was a major step with the indication to modern simulation. I give credit to our friends in anesthesiology who started in 1920s the first ladder-lay model which we used for CPR, and then it was modified in various stages at various institutions with various degree of SIMMAN, SIM1, SIM2, SIM3, which were used for creating clinical scenarios and then train medical students and residents. Simulation in non-medical communities. I think you will be surprised how simulation is used in every other profession except medicine before 1999. And I think simulation training is well established in military, aviation, NASA, and gaming industry. All the machines are tested multiple times before they are used. Flight simulation is extensively in the civil aviation to train pilots and other flight crew workers, civil and military aircrafts. It's also used to train maintenance of the engineers in aircraft system. The military use of simulation for training soldiers and military medical personnel to teach the modern skills. All the new weaponry is trained, soldiers are trained on those. Look at the birth of aviation and simulation training in civil aviation. That is, I think, the ideal model we need to adapt down the road. Wright brothers in 1903, first they made a wooden aircraft, then they made the real one which they flew it, tried many times, they failed many times, but then in 1907 in French, they made a real simulator that will try on this multiple times, then will increase the distance, then will go transatlantic and get it. The present simulator, if you look at it, is a very well technically oriented, and you have to do on a regular interval. Simulation and aviation industry, the flight industry established simulation as a basis for training that has become widely accepted. Flight simulators improved pilot skills. Certification is required on a yearly basis for them. Recertification the simulator has to be done every 6 months, and intensive simulation required to pilot the different aircrafts. A 737 pilot cannot fly a 747. 747 pilot cannot fly a 380, which is a new. So we have to adjust this model in our healthcare field. If you look at it, what happens in aircraft, when you take a flight, it looks very easy. You enter a plane, you flew, and you land. It takes a lot of effort on the aviation industry. SOP. SOP is a standard operational procedure. There are checklists, there are balances, and there are protocols. They have to be followed. Briefings. After every flight, there is a briefing. What was right, what was wrong, what's needed more to improve. And that has to be applicable in the healthcare. Team training is very important. And I think we have now stepped up quite a bit on team training, whether it's surgical, whether it's medical, whether it's nursing, whether it's PAs or mid-level providers. A renaissance in the healthcare about simulation. It all started in 1999. And you might have heard it, IOM report, it was in the news everywhere. When Atul wrote his first book, Are is Human, where he reported that we make mistakes as physicians, and the IOM came up with a report that at least 44,000, if not possible 88,000 patients died of medical errors done by the healthcare workers. At that time, the first rule came in US is we put limitation on the working hours of the physicians, which is 80 hours a week. And then slowly there are a lot of other requirements have been put in. So the first wind of change after 2000, intense focus on the quality and safety in healthcare came in by our different responsible organization who takes care of the healthcare and their education, which was our ACME, LCME for medical schools and nursing. Then call for educational reform across the continuum on professional development. That are the healthcare workers competent enough to start taking care of the patient? And that came up from CMS. Everybody knows Center of Medical Services, which all the dollar money for healthcare comes from them. AHRQ is the hospital organization. And then the Joint Commission, which certifies every hospital in the United States. At that time, the recommendation of IOM came in 2000, use simulators to ensure that clinical training is safe for patients. Develop simulators to use in skill assessment. Use simulation technology to improve individual as well as team performance and their assessments. And use simulation for problem solving and recovery from the problem. You make a mistake, investigate what happened, and then get to the problem. Then people start questioning, asking in our healthcare field is why to do it. And there were some positives, there are some negatives. It is inexpensive as compared to life of a patient. It's cost effective. Enhance learning objectives. Accommodate different skill levels. Every physician or healthcare worker is not of the same caliber. We need to have at the same level field. Safety engages with scenarios, and virtual training can be pursued. In simulators, we can take a task, make a mistake, correct that mistake in the next attempt, then you replay it, and then it is getting reviewed. So I think it's an immediate feedback on those simulators. Then there is another wind of change which came in in about 2005. And that was that little mind-boggling for us. The new accreditation model and standards. The ACGME came in that every institution who has a teaching program must have a simulation center. LCME came for all medical schools. Medical students should be trained on certain procedure in the medical college before they graduate. And the same has happened to the nurses. Then the next one, which is still very troubling to every physician, even in states, evolving requirement for maintenance of certification and licensing. So the All American Board of Medical Specialists and state medical boards now require that physician should provide us evidence of 50 hours of medical education on simulators at the time of relicensing, which happens every 4 years for every physician, or maintenance of certification by each specialty board, which is every year now. It used to be every 10 years, but now this year it has been every year. Then the third one is pursuit of innovative simulation-based education and training. The American College of Surgeons came and they say, okay, we will find solution to these, and they started the Accredited Institute of Simulation Training. Simulation is not new at all, as I mentioned. Confucius in 450 BC made this statement. Tell me one, I'll forget. Show me one, I might remember. Involve me in one, I will understand. So on the same basis, if you look at it, education and simulation, how the retention rate stays. If you lecture without audio visual, just I'm talking to you, you are going to absorb only 5% of it. With the audio visual, you might absorb up to 20%. Like I am doing PowerPoint slide, you might retain 20%. If we do by animation in simulation, maybe 50% with web seminars and local presentations. If we do real simulation, you might absorb 75%. If you start teaching simulation, then you might, and your trainer might retain up to 90%. So this is the model which we have working on simulation now. And at this point, we have now established a train the trainer course that all trainers who are teaching may not be, that they are not trained well to teach. So that's another thing which is coming up now. Train the trainer course. It's a 4-hour course. We give it on weekends. Now the simulation in primary care specialties, and towards the end I'll touch some surgical specialties too. So primary care physician we consider internal medicine, family practice, pediatrics and OBGYN, because they are the primary care provider to the patients. And then we have some medical specialties. I'll show you all the simulators which are in existence now. What kind of skills we can teach in simulation? Technical proficiency is measured by how much time you take to do a task, number of errors you make, and do you need assistance in that particular task. It can be just a lumbar puncture. It can be just attempt to put in a central line. So those things, those are technical skills. And then the non-technical skills are becoming more and more important. Teamwork. Are we working as a teamwork to get the patient best, cost-effective, safe, and quality care? Communication. Is the team communicating with each other? 88% of the medical errors we saw were made due to either no communication between the team, miscommunication, or third-hand communication which was not right. Judgment. When we start putting our individual judgment in the patient care, we are going to make mistakes. And then now we have started a leadership course, which is a 1-week course when we kind of trying to get the cream of the crop who can propagate the simulation in the country as well as abroad. The first column, if you'll see, there are 13 things. We expect that every physician, not barring to any specialty, should know all these procedures. OSCE, central line, arterial line, intubation, airway, thoracocentesis, suture and knot tying, ultrasound. Ultrasound is replacing, I think, our stethoscopes now, looks like. NG tube and Foley catheter insertion. Chest tubes may not be, but you should be able to do CPR as well as some biopsies, fine needle biopsies in the office. In the surgical, we have all the minimal invasive as well as dissection lab as the human beings practice and the animal model. So OSCE is the objective structural clinical examination. It has been done before. It's now being well organized and formulated with a curriculum. It's a versatile multi-purpose tool that can be utilized to assess healthcare professional in a clinical setting, can evaluate areas most critical to the performance of the healthcare worker, such as communication skill, how we communicate to the patient, and ability to handle unpredictable patient behavior. Every patient is not the same. So we need to look at their behavior and try to adjust our talk to that patient's requirement. This is our OSCE area. We have 20 rooms. There is a model there sitting. There is a physician sitting there, and they are conversing. It's being taped at the central station. That is reviewed by their preceptor, where they made a mistake. And then the feedback is given to the trainee. Central line placement, I think this is important. Actually, if our infection rate goes more than 2% in the institution, the physicians on that floor will be recertified in searching the central line. Basics for fluid management and critical care setting. Placement can be done ultrasound guided now, very easy, whether it's IJ, whether subclavian or femoral. Simulation will decrease incidence of line associated infection, arterial puncture, and iatrogenic pneumothorax. These are the various models available for in the simulation lab where they can practice and get certification on these things. Arterial line placement, same thing, importance of continuous blood pressure monitoring, not used much on the floors, it's only in the ICU or in the operating room. Simulation for ultrasound guided and palpatory method, both can be used, and simulation improves Seldinger technique of each healthcare worker, because sometimes even our nurses on the floor or in the ICU put arterial line themselves. These are the various models for that. Intubation, it's a basic skill, a must for airway protection for every physician. And I give you an example of this. One time I was traveling from New York to Bangkok for a meeting, and there's a patient who collapsed. There was a nice physician. I was just watching. I said, and he did intubation. So I think we need to learn it. A useful skill for any physician in any setting. Ergonomics and efficiency can be improved with simulation. These are the various simulators available. Everybody practice. They get certified, and they have a yellow card after they get certified. So they can keep the yellow card in their pocket, and then they can show on any floor, and they can do this. Thoracocentesis, critical care skill for large effusions. Now we are much better off because we have an ultrasound with us. Before we used to tap it and just put a needle in it. Useful centers lacking interventional radiology. For them it's very important. Making use efficient and prevent complication like pneumothorax. These are the various modules available for thoracocentesis. Suturing and knot tying. I think as a primary physician, we need to have some sort of training that in case there is a laceration, we can be able to suture them. And these are the various models available. You can done in about 2 hours. Everything can be done, taught and certified. Basic ultrasound is getting more and more important. In medicine, a lot of people are using in their offices now. Lately I saw a pocket-held ultrasound, which is a small one. Endocrinologists are using their office for FNA for the thyroid nodules. GI people are using their office as a screening. Only disadvantage is they cannot produce a report on those. For outpatient clinic, examination of fetal heart sounds and presentation, which OBGYN are doing. For trauma, we use in the trauma bay. And the drainage of breast abscesses and cysts in the clinic is done regularly. These are the various pocket held, and this, if you look at it, is the most of the offices will have this, which is a computerized ultrasound machine. NG tube and Foley catheter, they are ancient. We used to call Ryle's tube, now we call NG tube. So we need to know how to insert it. And I think it's important for every healthcare worker, including our nurses. Chest tube placement, I don't expect the primary care physician to put it in, but in case there is a need, they should be able to put in a needle in the chest for tension, pneumothorax or something. These are the various models are available. It's ultrasound guided versus manual. We can do it. Simulation in pediatrics very important. And they require a yearly certification for every neonatologist in US. New approaches to medical education to enhance resident and attending training. Both are trained equally. Resuscitation training program is advanced pediatric life support. Neonatal resuscitation program that has to be taught and upgraded every year. These are the various modules available where we teach in the simulation lab. Obstetrics and gynecology, this is another specialty where our physician, they are required to have yearly certification on dystocia model, C-section model, and a neonatal distress. So simulators mimic clinical events that have shown to reduce mortality. They can be birth canal defect, C-section, and robotic intervention. These are the various things available. This is a C-section module, hysterectomy simulator, and the virtual reality simulator for what we can teach every one of them. Simulation in cardiology. This is not required when they appear in the American Board of Cardiology. Understanding and refining systems to improve patient outcomes. ST segment elevation MI simulation, very important they're becoming because we are getting a lot of patients and we have now door to balloon time for every patient in every hospital. It cannot be more than 30 minutes. If it's more than 30 minutes, it's reviewed. Simulators for running codes and cardiac lung ultrasonography, because they have to do on their own patients. We can't wait for other people. Cath Lab Simulators for Cath team. And if you look at it, these are the simulators available now. This is a Code Blue VR simulator, Angio Suite simulators where they practice how to put the catheters, how to inject dye. They do everything. And this is our HeartWorks transesophageal echocardiogram simulator. Oh, where is that gone? And this is our Code Drill Blue in the Cath Lab. In pulmonology, There's a rising role of simulation in primary care, residency, and pulmonary fellowship. Positive training outcome with simulation. Vascular access, bronchoscopy, intubation, and now EBUS, which is the endobronchial ultrasound. Simulation program established by American College of Chest Physicians. They have set up a curriculum which has to be done. And these are the various simulators available. This upper one is a bronchial simulator. This is a EBUS, and this is a virtual reality intubation drill. Gastroenterology. That's another field which is evolving for simulation. And if you look at it, what is available now is a Koken colonoscopic mentor. This is the simplest one we have. And this is the costliest one we have. EndoSim endoscopic mentor. This itself costs about $180,000. And then we have to buy each module, what procedure you want to do. It has a 3D mentors, and then we have the ERCP module included in that endoscopic sim. I'm going to touch quickly the surgical specialties. Surgical specialties is vast, so let's see what. Ultrasound, every resident graduating in US must have a certification in ultrasound. Despite the development of ultrasound courses by ACS 2 decades ago, many residents still lack formal ultrasound training. So now there is a certification required. It's needed in the office, emergency department, operating room, and ICU. It's a valuable addition to general surgeons' armamentarium in diagnosing breast, thyroid, parathyroid, and vascular pathology. Courses in bedside echo, central line placement, and FAST is done. These are the various available to us. Computed simulator. This is a FAST which is done for abdomen in every trauma case, central line placement, and for the breast pathology. Fundamentals of fuse. I think this is very important. Some of the surgical and even endoscopic centers forget how many kind of electrical energy devices we use. So we have created now fundamentals of use of surgical energy instruments. And they are many. There are 10 modules. They are using all the energy devices, ligation, harmonic, ABC, UF, Cusack here, and then the radio frequency ablation instrument. We need to learn them before we use them. And these are the various, I put in just few of them, that they are different, and we need to understand what is the physiology and what is the maintenance of those instruments. This is a minimal invasive surgery which every surgical specialist is using now. This is FLS, which is a fundamental of laparoscopic surgery. There's a certification. There's a cognitive part, which is multiple choice question, followed by a technical part, which is a 5 technical skills, and you have to pass that, get certified. These are the 5 objects you have to do: peg transfer, pattern cut, lightning, loop, extracorporeal stitching, and intracorporeal stitching at a particular given time. Minimum time you have to do it, and then you can have second attempt. You have to pass the course. And these are the lab. Then we put modules in these things. They can do every procedure on that lab mentor, whether it is lab chole, incisional hernia, gastric bypass, and suturing. So they're available in every category. Endoscopic surgery and simulation, same thing. It is a certification program to assess surgeons' skills and knowledge. A validated curriculum has been developed by Society of Gastrointestinal and Endoscopic Surgery, which is SAGES. There's a cognitive skill exam and there's a technical exam in this. And if you look at it, this is the EndoSim, which we also have at our center. It has 13 modules, which they have to do before taking any exam. and then they can go on the exam. There are those 5 skills they have to pass, and then they go to the advanced thing where every procedure which is needed in endoscopy, whether it's a gastroscope, colonoscope, ERCP, they can train and get certified. Vascular surgery is a little more extensive now. It has 29 modules. There's a review process. It's a logistic-based simulation, and it has given you evidence of multiple procedures done in vascular surgery. So this is the vascular VR simulator, and actually we use the same for cardiology, because they can put the catheters, they can go anywhere, they can fill up the aorta, the cardiac chambers, so they practice on this thing. Orthopedic surgery is very evolving now. Orthopedics training is the more efficient with simulators. Multiple training simulators for open surgery are available. Multiple surveys and prospective studies have shown improved patient care. And if you look at it, they have the joints, the plating, they can do the plating, and they can do the internal fixation. So all can be practiced. Same it is ENT, highly technical demanding specialty, and despite lack of evidence in outcomes and limited high validity simulators, we are not still developed fully. People are trying, but we have simulators available for mastoidectomies, endoscopic sinus surgery. And these are the 2 of them. This is the endoscopic, and this is virtual. Ophthalmology, sleep learning curve, direct fluoroscopy, fundoscopy, indirect ophthalmoscopy, cataract simulators are available now. And that is how they do. There are 2 German and 2 Japanese simulator which they have created. This is the eye exam simulator from Japan, Eyes Direct from Germany. This is the one which we use it. This is a cataract surgery simulator which is from Germany, and this is the eye exam from Japan. Thoracic surgery, another one. We do for thoracic surgery attending as well as our fellows, we do a boot camp in the beginning of the year. It's a limited literature that's available, and they have lot of thoracic for lobectomy as well as for practicing just pleurodesis and put a VATS. So these are the simulators available in the thoracic. Neurosurgery, that is another field which is picking up now. Significant interest to explore and utilize simulation and virtual training. Multiple aneurysm and spine courses available, up-to-date simulators. And neurotouch simulators have changed the way we look neurosurgical simulation. And these are few available. We have this echo microsurgery simulator which every fellows in plastic as well as neurosurgery must do and pass it. Now I'm going to touch a subject which is becoming very important for healthcare worker as a team. So we have now established a team step training. And team step is team strategies and tools to enhance performance and patient safety. That stands for team step. Communication failure, as I mentioned, is a leading cause of adverse events in healthcare. Whether it's done from pharmacists to give the wrong dose or wrong medicine, nurses on the floor, mid-levels, residents, fellows, attendings. Everybody is included and they are part of the team. So team step is an evidence-based teamwork system for improving patient safety within any organization, for improving communication and teamwork skills amongst healthcare professionals, a source for reading to use material, and a training curriculum to integrate teamwork principles into all areas of healthcare system. And this I think we are taking from our civil aviation friends. They have a book. Before the flight, they go through the book page-wise. And we are creating the same thing now for the team step training. Scientifically rooted in more than 20 years of research and lessons from the application of teamwork principles, this team step initially was developed by Department of Defense, which is DoD, and the Agency for Healthcare Research and Quality. So with their help, now we have introduced into journal simulation centers. Now, team performance, what is the outcome of team performance? We need to understand. Without teamwork, consequences of error is greater. If we don't work with the full 5 fingers in the hand, we are going to make mistakes. We should be knowledgeable, we should be skilled, and we should not have attitude. Once these things come in balance, you will have the best patient care and outcome. Now, after this team training, the debriefing is very important. And debriefing is done on an individual and team as a whole. We need to learn and thinking about what they did, when they did it, how they did it, why they did it, and how they can improve. If they can improve these 5 things, the outcome of team performance will improve significantly. Ultimate aim is patient safety, and that's where we are going with the simulation. Now, how do we assess simulation? And we have a lot of models. We have backward design method, Kirkpatrick evaluation model, but most of the time Miller pyramid model works the best for us. We see from the bottom to the highest peak of the triangle, and we try to reach to the peak. Now, this is slide where you'll be surprised how regulatory bodies in US has involved themselves. For medical students now, and I think people here to realize that USMLE 2, they introduced the OSCE now. We have to go through those exams. It's done only in one center in Philadelphia, which is cumbersome, costly for everyone, but it's there. So LCME has introduced standardized patient-based clinical examination as USMLE Step 2, introduced in 2004. For residents, in every specialty, certification in simulation is required for the board examination. If you look at Food and Drug Administration, any device is invented, it goes through first the FDA. They want to have simulated results on that, and they approve it at that point. So if you look at the coronary and cardiac stents, as a condition of its medical device approval for carotid stents, of physicians to complete training of a task-based simulator before they can use stents in eligible patients, whether it's cardiology, whether it's vascular surgeon or neurosurgeon now. Nursing. In Canada, OSCE is introduced as part of registered nurse licensing examination. So they are putting hands on these things. Sooner or later, it will be in every field. So to the solution, American College of Surgeons kind of came forward. 2 organizations now offer a standardized simulation accredited institutions, which is American College of Surgeons and Society of Simulation in Healthcare. Other organizations, some of the subspecialties, they have their own, which is the ASA, American Society of Anesthesiologists, which started in 1920s, 30s. ASCOG, which is a gynecology obstetrics, because they have a yearly requirement of certification by simulation. And SAM, which is a Society of Academic Emergency Medicine. At this time, around the world, there are about 180 accredited institutions, which is 100 by American College of Surgeons and Society of Simulation in Healthcare. We have about 80 of them. So all around in Europe, in US, South America, actually in some in Asia now, we have accredited educational institutions which are accredited every 5 years by the American College of Surgeons or by SSIH based on their performance, outcomes and everything. So I think it's work in progress. This is our center we created in 2005 at a cost of about $7 million, which is one center we have dedicated to the orthopedics and neurosurgery, and then one for all other specialties, a 16,000 square feet area. But there are still gaps in simulation. What's the main problem we are facing is the faculty to teach. Everybody doesn't want to get involved in simulation. So that's why we put this train the learner program. And courses are there now. We are advocating every full-time faculty at our institution must go through that in every specialty. It's any inadequately trained faculty, which we are trying to solve. Focus on simulators rather than curriculum. Every society has their curriculum set up. Everybody is looking at that curriculum, not on the faculty. One size never fits all, so we have to adjust according to the specialty. Inadequate training pathways to ensure acquisition of proficiency during the introduction of new technique and technology of practicing surgeon. It's coming up. Every year there is something new, whether in surgery or in medicine. There is a competition between simulation-based training and clinical experience for residents. Inadequate resources and cost. Institution has to put up money. And I think what's going to happen in future, we are going to have this private standing simulation center pretty soon. This is a final note on simulation and patient safety, because everything we are doing is based for quality, safe patient care. Simulation has great potential to improve patient safety. Early evidence suggests that the method of education leads to increased patient safety. We have a lot of publications. It is not fully adopted and incorporated into all levels of medical education and training due to the lack of definitive proof that it leads to improved patient outcome and decreased cost. So we have to believe that thing. So I think in the end I can tell you the scenario has changed. You see one, practice many in the simulation lab, get competent, then do many, and then teach one. Now lastly, I just want to, the slides are not in this presentation, is the new wind of change which is coming up now very fast, is the cybersecurity and artificial intelligence integrated into medicine. Cybersecurity will be our data collection and safety of that data, and artificial intelligence will be used in various procedures we do. Now SAGES has just started last year a pilot project for 2 procedures, lap chole and sleeve gastrectomy. The chips have been put in the instruments. Now if you make a mistake or wrong move, there will be a red signal on the screen. It will let you 3 times do that. If you still are stubborn, you are going to make mistake and it will be recorded. So that's how the AI is going to influence our practice and pattern down the road, maybe in 5-10 years. So I think with that note I'll close, and if there's any question I'll be happy to answer.